Good morning, and I acknowledge each and every one of you for being here. And I thank the team, Diabetes India, especially the organizing team, and Dr. Bansi Sabu for giving this opportunity. And I'm really thankful for this topic, artificial intelligence in preventing hypoglycemia. Nothing better than this. If I ask the people sitting out here, suppose my type 1 diabetic patients don't get hypoglycemia, what will happen? First thing, I mean, you are not giving sufficient insulin or sufficient doses of insulin. You are not, but you are maintaining a good HbA1c of less than 6.5 and no hypoglycemia. It's like DCCT had a U-shaped curve. The HbA1c goes down, the hypoglycemia goes up. But if you have only one curve of HbA1c going down and no going up of hypoglycemia. So this is what we are looking up to in today's world. We are actually trying to use artificial intelligence in preventing hypoglycemia. Like when the patient gets hypoglycemia, you come to know. But if I can tell you 2 minutes later, you're going to have hypoglycemia, take care. So that is what we are actually trying to look into, and our patients will have least chances of getting hypoglycemia. And what we are bothered is, like Madam also talked about, type 1 diabetes is the very critical one where hypoglycemia is very, very common. We have type 2 diabetics in special situations like CKD and chronic liver disease, and patients on special populations like elderly who are at a very high risk of hypoglycemia. But unlike type 1 diabetes, who are at a risk of hypoglycemia on a daily basis. So on day-to-day basis, they are at a risk of hypoglycemia. So this is the opportunity which I got. So this is the presentation agenda, the challenges, the solutions, the clinical data, and the real world. So hypoglycemia is a silent threat. And in the last presentation, you heard about autonomic neuropathy and hypoglycemia unawareness, which is again a very, very crucial to understand because patient will not have symptoms of hypoglycemia and they are moving with hypoglycemia. And they actually are picked up with severe hypoglycemia most of the time. So the physical risk is seizures, coma, and cardiovascular events. Psychological is anxiety, sleep disruption, and burnout. And economics is significant healthcare costs due to emergency admissions. If one admission in a corporate hospital with hypoglycemia is going to cost you not less than 1 lakh of rupees, at least. The scope of the problem is despite advances in insulin analogs, hypoglycemia remains dangerously common in type 1 diabetic patients. 2 to 3 severe events per year, 42% worry about nighttime hypoglycemia, and 100 minutes per day spent in hypoglycemia. So, can you imagine? This is the burden of this particular problem. Now, paradigm shift to reactive versus predictive. This is what I was talking about. Today, the older version used to be the traditional CGM used to be reactive. Alerts trigger after the threshold is crossed below 70. So action is taken once the damage has already begun. But today it's predictive. Machine learning algorithms analyze rates of change to predict hypoglycemia 20 to 30 minutes in advance. So that is what is very, very important. And we have today uh, uh, pumps which have got a suspense. Like if your sensor detects a lower sugar, it automatically suspends the pump. So it stops delivering insulin. So the child will not get hypoglycemia or a severe hypoglycemia. So these are what we are actually looking into. So how artificial intelligence forecast glucose? There is an input data, CGM, insulin on board, and carbohydrate intake. The algorithm is model predictive control or PID. Algorithms project the glucose trajectory into the future, that is the horizon, and automated actions. If predicted glucose is less than 80 in 30 minutes, basal insulin is suspended or attenuated immediately. This is what is very, very interesting. And the level 1 AI is PLGS system. The airbag for diabetes. This was the first predictive low glucose suspend, was the first commercial application of AI in pumps. The Medtronic's 640G tandem basal IQ function was to stop insulin when low is predicted. Resumption restarts once glucose stabilizes. And impact is it reduces duration of hypoglycemia without significantly increasing hyperglycemia. Level 2 is hybrid closed loop. This is the HCL system, hybrid closed loop system, the 780G, which is very, very popular today. It take it a step further. They don't just stop insulin, they modulate it. And using advanced PID or MPC algorithm, these systems increase basal rates for high and decreases for low, aiming for a fixed target. And believe me, patients on 780G are doing phenomenal. They have a HbA1c close to 6.5 and or maybe less than 7, and very, very lesser chances of hypoglycemia. Very few hypoglycemic episodes been reported in these people. The artificial pancreas approach mimics the beta cell function more closely than even before. The study spotlight, the pivot trial, was the landmark multicentric RCT comparing control IQ technology versus sensor augmented pump therapy. This was in 168 participants. The key metric was time in range between 70 to 180 and time below range, that is less than 70. And what we saw, the hypo reduction was very, very significant from 2.6% at baseline to 1.6%. Time spent in hypoglycemia decreased significantly. And the important thing is the advanced hybrid closed loop. The FLAIR study evaluated the Medtronic 780G, which featured auto corrections, delivering bolus insulin automatically. Comparison was with 670G, the previous generation. The results was reduced hypoglycemia while simultaneously correcting high glucose. So we are actually taking care of what Dr. Ketan said. ये hyperglycemia रहेगा तो hypoglycemia नहीं होगा. But here you will not have even hyperglycemia and you will not have even hypoglycemia. This is what actually we are looking forward. And safety was zero events of severe hypoglycemia in the ASCL group. And the important part of this particular study was the quality of life, both in the parents and the child, was significantly improved. That is what the distress which is there in the parents of a child with type 1 diabetes was remarkably less in patients who were in the child who were receiving 780G. So this is one data which is very, very important to understand, that they are living like a non-diabetic population going to school and working. The FLAIR study time in range impact was very, very significant. The ACL algorithm improved time in range from 70 to 180 significantly without increasing hypoglycemia. And the real world evidence came from beyond clinical trials. And they have controlled environments. Does AI work in the messy reality of daily life? The cloud data analysis, and the finding was the real world users often achieve better results than trial participants because AI adapts to their uh, specific lifestyle regularities. And real world evidence of 10,000 plus patients will find 96% of users reported better sleep, 0.6% time spent in severe hypo, that is less than 54, and minus 40% reduction in hypoglycemia events. So you can imagine the AI supported is such a remarkable change in hypoglycemia. And under the hood, the machine learning algorithm is, while current pumps use MPCs, PIDs, next gen research focuses on deep learning. And this is what we are going to get in future: long short term memory, a type of recurrent neural network perfect for time series data like glucose trends, physiological awareness like models that learn insulin sensitivity, changes during exercise or illnesses, and personalization like we are talking about personalized medicine. The AI learns your specific reaction to pizza versus salad. This was presented at the EDA this year, and the leading edge interactive app employs cognitive computing and analytic technology developed into the first ever artificial intelligence. This was by Medtronics, IBM Watson, and this is what was this is the pictures which I took during the presentation. That you can actually see the sugars, the Saturdays, the other days, and you can actually act on them on the day-to-day basis automatically. The sugar IQ algorithm takes into account repetitive behaviors, user preferences, and feedback based on trends, and to generate personalized graduated prompts aim to encourage improvements in care by learning each user's behavior and preferences to detect opportunities for improvement and create prompts to guide AI learning, essentially problem solve for the patient. So if you put your data on the app more and more, the AI is going to help you much better than what you are actually seeing on a daily basis. So the features of Sugar IQ app include personalized insights that reveal time and day of behaviors related to glucose levels, linked to bolus demands, rapid change in glucose levels such as post insulin highs and lows, time-based actions, and meal content patterns. So, like someone is having a Gujarati meal, someone is having a Hyderabadi biryani, someone having for like me having a Marwadi khana at Ranchi. So every meal is different. So when you start feeding the data of different meals, this is going to generate your insulin requirement and basal requirement accordingly. That is the best part of this particular app. So AI in hypoglycemia prevention, non-invasive approach, the voice approach. I still remember one of the guy from IIT Dhanbad presented recently at Devghar, and the RSSDI, Dr. Anuj Maheshwari was there in the meeting as invited for research retreat. That according to voice of the person, they can actually predict the glycemic load, and this is what they are looking into. You will find that there is a suppression of voice, there is an aggression of voice, and that is what is going to predict hypoglycemia. Similarly, the facial image analysis is going to be another feature to be taken into an account by the AI. Integration of deep learning techniques with facial image analysis holds promise for personalized healthcare solutions tailored to individuals with diabetes, facilitating early detection and intervention for improved glycemic control. So protecting the vulnerability is very, very important. As I said, we are actually looking into like a non-diabetic child growing up in a regular basis, and not even reducing the number of years of life. This is what we are looking. We know that there is a reduction in years of life of a type 1 diabetes. We are looking for a normal life for all our type 1 diabetics. AI in standalone CGM, that urgent low soon alerts is going to be there. And the system comparison is going to be another important thing. Hyper prediction to hypo suspension to auto corrections to TIR outcomes. So this is what is we are looking for in AI generated prevention of hypoglycemia. There are a lot of current challenges like connectivity, the sensor lag, the exercise patterns which are going to be different. The human factor still holds the most important place. See, you are having a pump, but you don't understand, you are not educated of using a pump or a sensor. The parents don't take interest in learning about it. That's not going to help you. The what we are looking into is you need to be educated the way it functions. Technical factors is also very important. Limitation of data and limitation of design. So the future is fully autonomous dual hormone system incorporating glucagon to raise glucose alongside insulin for true biological mimicry, neural network integration, and the goal is set and forget, zero user interaction required. So these are the key references which I have taken for this presentation. So I thank you all for the patient listening, and I thank the organizers once again for this opportunity. Thank you very much.